Thank you, sir. Welcome back, ladies and gentlemen. So after the morning tea interval, we are starting our next symposium on cardiac electrophysiology. One of the moderators is already on the stage at the moment, Dr. Asanga Dunivila, Senior Consultant Cardiac Electrophysiologist. He'll be joined by Dr. Suresh Kotaguda, Consultant Cardiac Electrophysiologist on the stage as well to introduce the lecture panel.
Good morning. Welcome to the session in electrophysiology. There are two topics involved in this lecture. First one will be delivered by Dr. Rohan Gunawardena. The topic would be risk assessment and management of sudden cardiac death. Then subsequent, the second topic will be done by Professor Mohan Nair online as virtual presenter. We'll do the two presentations first, and then we'll take up the questions at the stipulated time. Dr. Rohan Gunawardena doesn't need any introduction to this audience, but just a few words. He's a senior electrophysiologist in the National Hospital, had been in Sri Lanka Heart Association and many other forums over this period of time. And he's the country representative of Asia Pacific electrophysiology unit. And he had been speaking on many topics in a variety of conferences up to date. So may I invite Rohan to deliver his lecture.
Good morning, everybody. And thank you, Asanga, for that introduction. And let me first of all thank the Sri Lanka College of Cardiology for inviting me to give this lecture. It's an honor for me as well because I'll be speaking the same forum as Professor Mohan Nair. I don't know whether he's here and whether he's online and can hear me. But he's the man who was behind basically the setting up of the EP services in Sri Lanka with us, and he made a great contribution. And so basically he is our mentor. Yes, so basically the topic is going to be the risk assessment of sudden cardiac death. The topic also included management, but there's simply no time to look at both these topics because these are two huge topics on their own. If you look at sudden cardiac death worldwide, you realize that most of sudden cardiac death is due to coronary artery disease. And if you include cardiomyopathies, then you have 90% of all sudden cardiac death occur in these two groups. The inherited arrhythmogenic syndromes that we deal in actually constitute a very small percentage of this number. But when you realize that a large percentage of sudden cardiac deaths in the cardiomyopathy group, whether it's ischemic or non-ischemic cardiomyopathies, are due to ventricular tachycardia and VF, then certainly the arrhythmogenesis or arrhythmogenic cardiac death is the end event in most of these cases. So it's a very important area. Now, when you talk about sudden risk assessment of sudden cardiac death, we have to look at two questions. Who is at risk of sudden cardiac death? And why do we want to assess risk? We'll take the second question first. Is it for prognostication? Well, not really, because if you diagnose a condition which might eventually end up with sudden cardiac death, we know that there are various other parameters that we use to prognosticate in those particular situations. For instance, there are risk scores and there are various risk factors that we use. And it is also not to decide on what medications we are going to use either, because for instance, if you diagnose a patient with heart failure, you are going to start them on beta blockers, ACE inhibitors, and spironolactone, which are known to be prognostically beneficial. You are not going to decide to start on these medications by assessing the risk of sudden cardiac death. So actually, the sole purpose of assessing the risk of sudden cardiac death is to actually decide on whether these patients needed ICD, and that is the most important point here. And who are the group of patients that we are going to assess risk on? There are obviously a large cohort of people who are at risk of sudden cardiac death, which are the ischemic and non-ischemic cardiomyopathies. Those patients with arrhythmogenic syndromes, and this last group, we are actually assessing the risk of sudden cardiac death not to give them ICDs, but to decide whether they are able to take part in competitive sports. I'm not going to talk about this group. And I'm not going to talk about the arrhythmogenic syndromes either, because each of these arrhythmogenic syndromes have their own risk factors and there are ways of defining or assessing the risk of sudden cardiac death in those situations. And it is again it is beyond the scope of this lecture to talk about electrophysiology syndromes. So I'll be concentrating on assessing the risk in ischemic and non-ischemic cardiomyopathy. Now, let's first of all take ischemic cardiomyopathy. How do we assess risk at the moment? It is entirely based on the ejection fraction. If you look at the guidelines from the American College of Cardiology and American Heart Association, they use risk factors in all their 3 initial criteria for deciding whether the patient needs ICD. However, and these recommendations are made solely on 2 studies that were done, the MEDIT-2 and the SCD-HEF trial. Right? However, there's a lot of controversy about the use of left ventricular ejection fraction per se for assessing the risk of sudden cardiac death. And this has been contested by various people in various parts of the world, and various other studies have also shown certain problems with the ejection fraction. We know that left ventricular ejection fraction is very good at assessing the overall mortality and the non-sudden cardiac risk. However, it is not very good at assessing the risk from sudden cardiac death. One of the factors may be that though LV ejection fraction assesses the overall LV dysfunction, it is not able to assess myocardial scar, which is the substrate really for VT-VF, which causes sudden cardiac death in this ischemic cardiomyopathy patient. So therefore, it may not be. And this is just a extract of one of these articles by Goldberg and others, and there are several of these articles and several people around the world who contest the use of LV ejection fraction per se for deciding on the risk of sudden cardiac death. And interestingly, if you look at these studies, from the results of the studies, it shows that the number needed to treat to save 1 life is quite large. So basically, depending on the ejection fraction that is used, it is from between 70 to 25 patients had to be treated with ICD to save 1 life. Putting that into cost, if you can translate it to cost, we are talking about spending approximately 17 million rupees or 25 million, up to 25 million rupees to save 1 life. That's a huge cost, right? Which also means that it's just poor specificity. So essentially, 96% of the patients that we implant ICDs in using this criteria will never ever get a sudden cardiac arrest. So that's something to think about. The sensitivity is also very poor, because we know that a lot of patients who go on to develop sudden cardiac death or sudden cardiac arrest actually have preserved LV function. So they have LV ejection fractions above the guidelines that have been suggested. 2 large registries show that only 20 to 30% of patients who go on to develop sudden cardiac arrest have the low ejection criteria needed to be included as in the recommendation for ICD. So that means you're missing a lot of patients who may actually benefit if they had ICD, if you use this ejection criteria alone. Again, another study, the Valiant study, showed that 50% of patients dying from sudden cardiac death after myocardial infarction actually have ejection fraction between 31 and 40%, and therefore you will miss them if you use the cutoff point of 30%. So we just show that the ejection fraction is a very poor indication or risk of sudden cardiac death. But cost is also better. Not even in countries like us, where we anyway financially we are constrained, but even the US they're worried that if they were to actually implant ICDs in all patients who need ICDs, that's about $350,000 per year, that you're talking a cost of $30 billion per year. So it's a huge cost problem as well. So the cost benefit also is a big issue here. What about non-ischemic cardiomyopathy? Again, we are using similar criteria to that. The second indication is a very specific for non-ischemic cardiomyopathy. I will discuss that a bit later. But essentially, if you look at the ejection fraction criteria, it's very similar to ischemic cardiomyopathy. And here, the evidence is even less robust. The recommendations come from subgroup analysis from the SCD-HEF trial and 3 meta-analysis of 3 small studies, and none of these studies actually showed a mortality benefit. So this is again a situation where there's a huge underestimation of sudden cardiac death. And we know that many patients with non-ischemic cardiomyopathy will die of heart failure and other causes and not sudden cardiac death. So again, using LV ejection fraction to decide on the need for ICD based on the fact that we are saying that if they have poor LV ejection fraction, they have a risk of sudden cardiac death is very inappropriate. And if you look at the overall mortality in non-ischemic cardiomyopathy, it is about 5%. And of that, only 1/3 is due to sudden cardiac death. So basically, your risk of sudden cardiac death in non-ischemic cardiomyopathy is quite low at less than 2%. It's worthwhile at this point just to look at the Danish study, which was done somewhere in 2017. Here they looked at a large number of patients, over 1,000 patients, who were having idiopathic cardiomyopathy, mainly idiopathic cardiomyopathy. And they looked at sudden cardiac death in patients with ICD versus optimal medical therapy. And they found that there was that ICD arm did not have a lower mortality. And there were some interesting outcomes of this. One showing that certainly in patients who were younger, there was definitely a mortality benefit. They also showed that women did not have any benefit in ICD at any age group. So that was another important point. One of the reasons that maybe the patients on optimal medical therapy fared very well in the study was that most of these patients had very high use of prognostically favorable drugs. And also, more than 50% of these patients were on cardiac resynchronization therapy. And we know that CRT alone significantly reduces the risk of sudden cardiac death in non-ischemic cardiomyopathy by various means. Right. So then if you consider that if differential ejection fraction per se is not adequate to decide on kind of assessing the risk of sudden cardiac arrest, what else can we do? Now, what about electrophysiology studies? Now, we know that this is actually in the guidelines where they suggest that in patients with ejection fraction less than 40%, that a VT study or an EP study will actually help in deciding the risk of sudden cardiac death, and this has been shown in many studies as well. What do? We put in the catheter into the right ventricle, and we do what we call a programmed ventricular stimulation, where we give a train of beats followed by an extrasystole. These extrasystoles are then decrementally added, and you can see, so in this particular strain, where we are having a strain at 400 milliseconds, 150 beats per minute, and then we give extra beat, which is S2. So S1 is the train, and S2 is the first extrasystole, S3 is the second, X3 is 4, and so on. Right. In this train, which uses 3 extrasystoles, there is no induction of a ventricular tachycardia. But when we added a 4th extrasystole, the patient develops a VT, and this is what we call a positive study. There are downsides to the EP study because they are shown that if you use only 3 extrasystoles, then actually you might miss 30% of the patients who actually may go on to develop sudden cardiac death. So that's a bit of an issue. But on the other hand, if you use 4 extrasystoles, you can have high false positive, because even normal people, you can induce a VT, VF by using a very, what you call, drastic protocol. There is a study going on called the PROTECT ICD trial, which may answer this question. The results should be available in 2021. Another useful tool would be, of course, cardiac MRI, because we know that cardiac MRI can quite very well delineate peri-infarct zones and extent of scar and objectively assess this. And we know that in ischemic cardiomyopathy, extent of scar is very important when deciding on the risk of sudden cardiac death. Various studies have also shown that in patients who are having CKD, GFRs of less than 6 and having GFRs of less than 60 millimeters per minute, there is no benefit of ICD. So this is another important area to assess the renal function. There are various other ECG parameters that have been studied, like QRS duration, QRS variance, and things like that. And particularly these two factors. The QRS complex fragmentation and the microvolt T-wave alternance has shown promise in certain studies, but are not maybe not important enough, maybe not kind of significant enough to be still incorporated into guidelines. Longitudinal strain by 2D echo also, there have been small studies which have shown that this might also be helpful in deciding on the risk of sudden cardiac death. This Seattle proportional risk model is interesting, and I will discuss that a bit later on. What about in sudden risk of sudden cardiac death in non-ischemic cardiomyopathy? We know that from the Danish study that older patients may not benefit, and they have actually put a cutoff line, cutoff age of about 70 years, saying that patients above 70 years with non-ischemic cardiomyopathy will not benefit from ICD. Similarly, they have also said that females may be at lower risk, and there may not be, again, their risk of sudden cardiac death is low. Now, we know that many non-ischemic cardiomyopathies have their genetic involvement, and various genes have been proposed, but this particular gene, the LMNA gene mutations, there are several mutations in the LMNA gene which are responsible for this defect, have been found in 6% of patients with non-ischemic cardiomyopathy, and which gives a very high risk of sudden cardiac arrest and sudden cardiac arrest, and therefore it is actually in the guidelines, and this should be used when we are talking about, if we available, when we are talking about non-ischemic cardiomyopathy. Cardiac MRI again plays a very important role, and if you can show that in late gadolinium enhancement, which is consistent with mid-wall fibrosis, which is also called replacement fibrosis, this also is very suggestive, or it's a very good indication that these patients are at high risk of sudden cardiac death. In fact, after the study, a lot of countries in the Europe and UK, they now go in for cardiac MRI studies in non-ischemic cardiomyopathy before deciding on whether need for ICD. Again, you can use various ECG parameters, and some of them, like the microvolt T-wave alternance, have been shown to have high negative value as well. The Seattle proportional risk model, this is very interesting because this was actually developed by a group of scientists in USA. They looked at about 10,000 patients with cardiomyopathy, both ischemic and non-ischemic, who are not on ICDs. And they looked at them for about 2 years. Out of this group, about nearly 2,500 died. And they looked at the death, and they looked at various factors that affected death. And then they created this model, and they showed that it's very interesting in a way, because you can actually go online and just put these numbers in. And I have taken 2 hypothetical patients. One is an older patient, 70 years old, both patients have similar ejection fraction, similar BMI. But here you have the older patient has a lesser systolic blood pressure, slightly elevated creatinine, slightly lower sodium, and diabetes. And you can see that the risk model comes up with a risk of sudden cardiac death versus non-sudden cardiac death. And here you can see the significant numbers will die of non-sudden cardiac death. So this is very important. And here it also says the numbers that will be benefit from ICD. And here you can see that if in this particular patient with these parameters, there's no benefit from ICD. You do not save any life years by putting ICD, and this may be a helpful thing. Whereas in the younger patient who has a better blood pressure, less the creatinine is normal, and sodium is normal, and no diabetes, has a very much higher risk of sudden cardiac death. And this is the type of patient who will benefit from an ICD. So this is a very useful thing to use. And this has been validated by various studies all over the world, including in Japan. So what about risk assessment of sudden cardiac death in Sri Lanka? Now we know that in our situation, if a patient has the criteria for the present criteria for ICD, we can order a local purchase in the government sector. We can local purchase an ICD for the patient. And so far, we have never been refused an ICD. So which means that the government is willing to spend on ICD if we request it. Right? But that's a huge cost. Remember that we are going to spend nearly 17 to 25 million rupees to save one patient life. And whether this is sustainable, we don't know. In the future, we may have more and more indications. We are going to ask for more and more ICDs, but with the health, whether the health budget can actually stand it, we don't know. And remember that eventually it is us who are going to pay for this. Right? So therefore, but in the privacy is a different matter because patients are paying for it, or it's paid by insurance companies. So it's not such a problem. But still, in my practice, what I do is I tell the patient, look, you have an ejection fraction very low. You are at a small risk, 2 to 3% risk of dying suddenly of a dangerous arrhythmia. But there is this device which can save you from dying. I also tell them that because patients think that, when we put ICD, everything becomes okay, but that doesn't happen. So I make a point to tell them, look, it's not going to help you. It's not going to improve your quality of life. It's not going to improve your shortness of breath. It's not going to improve your tiredness. Nor is it going to make you feel better in any way. It's only going to prevent you from dying. And sometimes patients, particularly if they're older, they say, doctor, I have had a good life, and I'm quite happy to die suddenly. And in a way, sudden cardiac death is one of the best ways to go, I would say. I would like to die of sudden cardiac death myself. Right? And so therefore, when you're talking to patients, it's also important to be realistic and tell them what it's all about. Also remember that there are complications of ICDs which can be quite terrible. Right. So I think I personally feel that as in this part of the world where our resources are poor, we must have our own guidelines, particularly for the public sector when it comes to the requesting ICDs and assessing sudden cardiac death. I think we should, as Sri Lanka College of Cardiology, take up this issue and produce guidelines for Sri Lanka. And maybe if at a bigger level, maybe the APHRS should do that for Asia, because a lot of Asian countries have the same problem financially as we do. We can use existing guidelines, look at the cost benefit, look at age and gender, and look at the studies that show that some ages in some age groups there's benefit. And consider EP studies, not only for patients who are just have ejection fraction between 35 and 40%, but even for those with low ejection fraction, and maybe for those with slightly higher ejection fraction, because we know that a lot of patients who die of sudden cardiac arrest have good ejection fractions. We must also consider renal function, because studies have shown that those with poor renal function do not benefit from ICDs, and they will die from other causes. And we can use cardiac MRI again. If you use cardiac MRI and you can reduce the number of ICDs from, say, by 4 or 5, you're still saving money. And of course, it may be very useful to use a Seattle proportion risk score, which has been validated in other countries as well in part of this risk assessment. So I think this is something that we should seriously look at. But we must also not forget that we can prevent sudden cardiac death. And that's an important thing as well, because if you can prevent sudden or developing or the risk of sudden cardiac death, then you can reduce the risk of ICD as well. One of the most important things in preventing sudden cardiac death or risk of sudden cardiac death is early revascularization. If you can do PCI, primary PCI early and prevent scar formation, that itself will go for a long way in reducing the risk of a sudden cardiac death in these ischemic cardiomyopathy patients. This is a very important thing, and this is something that, of course, still the cardiologists are trying to do, but this is very important, I think, for reducing the risk of sudden cardiac death. Early optimized optical medical therapy in heart failure is very important, and we must say optical medical therapy so that we must optimize the drugs that we're using in heart failure. Right? And also, we know that cardiac resynchronous therapy per se will reduce the risk of sudden cardiac death. And therefore, optimal timing for cardiac resynchronous therapy again is very important. There's no point in referring patients for cardiac resynchronous therapy when their ejection fraction is 15%. Other important aspect is resuscitation of sudden cardiac arrhythmia in the community. We know that most patients who die of arrhythmias and sudden cardiac death happens in the community. So if you can prevent that from happening, then basically it's like this. So you have a patient who is arrests in the community, is resuscitated. The moment that happens, the patient moves from primary prevention to secondary prevention. Now, we have no problems with secondary prevention ICDs, but we know it is beneficial, right? So if you can move the patient from primary prevention to secondary prevention, that's a very, very useful thing. How are you going to achieve that? Community external defibrillators might not work in this country because the cost is such, and we can't really put them in places where there are a large number of people. I mean, in Sri Lanka, everywhere there are a large number of people. Other than for the COVID situation, we find them all over the place. So we can't be installing, say, ICD in maybe the Sunday Polo, for instance. It's not practical, right? And other thing is,
Rohan, excuse me, you got last 1 minute.
Can we imagine that a lay person is going to actually take one of these cardiac defibrillators and defibrillate a patient? I mean, we know that doctors who have been trained to do this in ICUs are really reluctant to do cardiac defibrillators. So you really cannot expect the lay public to do that. But one thing that can be done is CPR training. And this can be done very effectively as part of the school curriculum. And I think they are hoping to set about this as well, where we have a subject called health sciences, and this is something that can be trained at that level, and then we can have this whole population of young people who have some experience in CPR. Right, so that's about all. So we can see that there are various issues with left ventricular ejection fraction being used only being used for assessment of sudden cardiac death, and therefore we need to do something about it at our level. Thank you.
Thank you very much, Rohan, for that comprehensive lecture. We quite a lot of interesting information, and I think you can sit on the podium, and we'll move on to the second lecture, and then there is a question and answer time. Let me introduce Professor Mohan Nair, who has been a great friend of us over this long period of time, and been very helpful for us to set up the EP services also in Colombo. And he had visited us many times. He already agreed to visit, and then this pandemic set it in. And he also has moved through several hospitals and presently holding a chief cardiologist post in the Holy Family Hospital, New Delhi. Mohan, I'll invite you to deliver your lecture virtually on the topic of resynchronization, whom and when. Over to you, Mohan.
Yeah, thank you, Asanka, for that introduction. And good morning, Dr. Suresh. Good morning, Rohan. And thank you, Sri Lankan College of Cardiology, for this invitation. As Asanka rightly said, I was really looking forward to coming over and delivering this talk, just to meet up with friends, as Sri Lanka is almost second home for me. So I'm going to talk about cardiac desynchronization therapy, whom and when. Let's start with a patient. This is a patient who came to us several years back, known case of dilated cardiomyopathy, class 4 symptoms, and was already on guideline-directed medical therapy, had 3 hospital admissions in 4 weeks. That's almost every week he was back in the hospital. The LV ejection fraction was 20%. The ECG showed left bundle branch block, and the Holter showed non-sustained ventricular tachycardia. Now, what are your options on these patients? Normally, you would say this is an end-stage heart disease, and you would like to talk about left ventricular assist device or cardiac transplantation, both of which have huge logistic limitations. Now, this patient, as I said, had left bundle branch block, and he was given this device called the cardiac resynchronization therapy or biventricular device. And immediately the QRS narrows, and you have an RBB, a positive in AVR, and an RS in V1. And what that does is that within 4 days following the implant, the patient becomes class 2, is off intravenous medications. And as I said, the ECG has narrowed from 150 milliseconds to about 103 to 110 milliseconds. Now, this is the X-ray before, and this is the X-ray after the device implantation. So what is this magical therapy called cardiac resynchronization therapy? As I said, technically we have on one end pharmacological therapy, which does form the mainstay of all heart failure therapies, irrespective of the region you are in, irrespective of the country you are in, irrespective of the social class. Pharmacological therapy is the mainstay, and we know that there are some very interesting new therapies coming up which will change the scene of scenario, as Rohan said, of even sudden death in these patients with heart failure. On the other end, we had transplantation. Transplantation, however, even the best of countries, they say, is like offering a lottery ticket as a solution to poverty. The number of donors so much, or the number of likely recipients so much outnumber the donors that are available, and the logistics and the costs really don't make this very commonly usable therapy in patients with heart failure. And that is why where the resynchronization therapy comes in. Before I go into who should get it and when they should get it, I think I'll just run through the science behind resynchronization therapy. Now, when there is heart failure or when the heart starts dilating and it's fibrosed, there is increasing intraventricular conduction defects. And that leads to non-synchronous ventricular activation, leading to abnormal ventricular filling and wall motion. It is most evident when it is left bundle branch blocked, because that affects lead activation of the left ventricle, which is the main ejecting ventricle of the body, of the heart. What cardiac resynchronization tries to do is a therapeutic intent of reversing dysynchrony with the use of biventricular pacing. Now, how much is this prevalence of ventricular dysynchrony? Different studies have shown that ventricular dysynchrony actually is seen in anything between 1/3 to 1/2 of patients who have heart failure. And also, there's an incremental risk of having dysynchrony as the heart failure clinical condition worsens. When you compare the general heart failure population to severe heart failure population, the incidence of intraventricular conduction defect increases. So there is dyssynchrony in the heart. What does this lead to? See, dysynchronous heart pumping is a wobbly pumping. That is, given the same amount of muscle, if you have a dysynchronous ventricle, that's far less effective in ejecting blood than the same muscle which contracts in a synchronous manner. And that is what resynchronization therapy aims to do, to convert a dysynchronous left ventricular contraction to a synchronous ventricular contraction. As I said, most of it is left bundle branch block. So most of the talk the rest of the talk is going to focus on patients with reduced ejection fraction and left bundle branch block. I will touch on the other exceptions towards the end of my talk. So how do we resynchronize? We are very well aware or very well adapted to seeing these regular pacemakers which have a lead in the right atrium and the right ventricle. The additional lead that is there in the CRT or the resynchronization therapy is a lead that can pace the left ventricle. People had tried initially to put up a lead directly into the left ventricle, but that had its own complications. Therefore, the accepted ways to put a lead into the left ventricle most commonly is through the coronary sinus, go into a posterolateral vein and pace the left ventricle from there. You can also, of course, if this fails, have an epicardial patch electrode put by the surgeon. Once you do this, so you see here On the left-hand side, the left bundle branch block, and this is the async. And suddenly, when you start pacing, the ventricles start becoming synchronous. And you can see the subtle difference in ejection fraction as soon as there is, and the QRS narrows, and you see that between the 2 pounds on the left, on the right, you see that it's the same heart, but it starts becoming smaller and ejecting slightly better. With that, you also see that the mitral valve flow patterns, which are indicator of left ventricle filling, also start normalizing. And this was initially tested on the bench and in small cohort of patients. It shows that it not only improved functional class, improved 6 minutes walk test, increased the peak oxygen consumption and the quality of life. Now, we must be very clear that most patients, and especially in the initial studies, the ejection fraction itself had increased only by about a mean of 6%. But that was enough for a failing heart. Imagine a patient who has an ejection fraction of 20%. He goes from 22% to 28 to 30%. That's a huge difference in terms of the heart failure symptoms and heart failure outcomes. Just now, Rohan said how important it was finally to see how much is the ejection fraction when you talk of not only sudden death, but heart failure deaths. So the whole story started in France, actually, from Cazou, who's an echocardiographer, and Claude Daubé, etc. This was the time I was in France doing my electrophysiology fellowship, and I know that the coronary sinus leads are all over the place. But over the years, there have been several studies that have been done to look at different aspects, not only of how synchronization works, but to improve outcomes and to see which patient should get this therapy. And you see here that the early studies were just for LV lead validation, but then we moved up not only in the number of patients that were enrolled in studies, but also looking at endpoints of morbidity and mortality. And now it is clear that cardiac resynchronization therapy, the right patients, does improve morbidity and mortality. And this improvement is over and above the standard, whatever guideline directed medical therapy that includes beta blockers, ACE inhibitors, and then you add the CRTD. Regarding cost effectiveness, as Rohan pointed out, the cost effectiveness can be calculated in very different ways and can be different in different countries. But at least for CRT, the decrease in number of hospitalizations and the decrease in man hours lost due to death and disability, at least in the European countries and Scandinavia, leads to a huge cost benefit in favor of CRT. And that is why from 2003 onwards, CRT forms a standard of care in patients who have been on optimal medical therapy and have still not doing well. So now we can try to understand. Now remember, over the years, in the initial stages, and if you ask any patient who's going downhill in a heart failure curve, it's good enough if the patient becomes a non-progressive. That is, there is a stable heart failure situation. But over the years, we've understood the patients who should get it, when the patient should get it, who are the patients who should get it. And there have been several algorithms like adaptive CRT, multiple site LV pacing, etc. And now we like to have the patient not only above his stable station or becoming super responders. Now, super responders are patients who start with a low ejection fraction, heart failure. You put a CRT, the ejection fractions become normal. Honestly, initially, there were some patients who were super responders. When I started doing CRT around 2002, I think, or maybe 2000 or late 90s, and I thought that maybe I put it in a patient wrongly, in a patient who had myocarditis. But we know now that many patients can be in this responder or super responder state. And that is what is the key in patient selection, and the device programming should aim for. So to make it simple, we know for sure that patients with left bundle branch block and ejection fraction, low ejection fraction heart failure for class 2 to class 4 ambulatory class 4 are class 1 indications for CRT now. Now they are 1A if the QRS is more than 150 milliseconds. They are 1B, the QRS is between 120 and 150 milliseconds. If the QRS is less than 120 milliseconds, then as of now, contraindication for CRT. Now, if there is non-LBB patient, RBB patient, or, for example, non-specific interventricular conduction defect that we often see in patients with fibrosed heart, there the indications become 2A. If the QRS is more than 150 milliseconds, you might still try it. 2B, which goes a little more towards 3 if the QRS is more than between 120 and 150 milliseconds. So the real patient who should get it, the patient who has left bundle branch block, QRS more than 120 milliseconds, preferably more than 150 milliseconds, and is class 2 to 4 on optimal medical therapy. However, this is where I think Rohan pointed out. There were patients where I said, when I started, I would have to put patients who had no option patient, like the patient I showed you. Increasingly, we have realized, and Rohan very rightly pointed this out, that if we are to select patients and have responders or super responders, and also get away with not having to put a combo device, that is a CRT-D, which is much more costly, but get away with CRT, which will decrease not only cardiac mortality, but also sudden deaths. That will be when the patient is in class 2. We don't want to put it in patients who are doing well on optimal medical therapy, but we certainly should start discussing and considering and planning putting CRT in patients who are going on optimal medical therapy to class 2. Class 3 is already a little bad. Class 4, to my mind, as Rohan rightly pointed out, is too late. And that's where, as your experience increases, the guidelines sometimes take time to change all these figures. But increasingly, we are very sure that the earlier you take a decision, the earlier you put it in a patient who qualifies the criteria, better are the results, both in terms of overall cardiac mortality and even prevention of sudden death. What about other patients? One of the challenges has been atrial fibrillation with the same criteria: atrial fibrillation, heart failure, left bundle branch block. It's almost impossible to ensure pacing. And increasingly, we've found that if you want to have the impact of resynchronization, initially we used to think that anything over 75% of the time if the patient is having synchronized pacing, that's good enough. For sure, now we know that the bi-way pacing time needs to be more than 90%, preferably towards 100%. So the only way we can achieve this in patients with atrial fibrillation is, one, to have drugs to really block the AV node to ensure more than 90% bi-way pacing, or do an AV nodal ablation and then do bi-way pacing. Or third is to try and see if in these patients, although it's a difficult thing to achieve, do a definitive ablation. Right bundle branch block, more than 150, class 2B indication or class 2A indication. But in my own experience, it should never be done. We've had a couple of patients, they didn't do well. What about narrow QRS patients with heart failure? And show some, there was a time when dysynchrony was, or indication for CRT was being indicated by what you found on echo parameters. But now it's very sure that narrow QRS patients, that the QRS less than 120 milliseconds is not a patient for CRT. Minimal symptom, yes. As I said, you don't want to put a device in here, but watch these patients very carefully. If they start becoming more symptomatic on the same amount of drugs, starts needing more drugs or getting into hospital, even a single hospital admission should alert you to the fact that this patient may need a device. And that's the time. It's the same in Sri Lanka, the same in India. We need to start talking about the cause and the fact that the patient needs a device. Do all patients requiring brady pacing, should we change from just right ventricular pacing to biventricular pacing? Why does this question even come up? That's because several studies have shown that chronic right ventricular pacing, which causes a left bundle branch block, can itself lead to myopathy. But right now, I think a balanced opinion would be that if a patient already has LV dysfunction and comes not with heart failure symptoms, but with complete heart block, this patient should preferably have a CRT than a right ventricular pacing. Also, in patients in whom there is a risk of heart failure, that is patients who have had an MI, patients who have have had revascularization, one must think theoretically of giving a CRT or a biventricular pacing than an RV pacing alone. And some of these issues are being now, in my last few slides, just introducing the topic of physiological pacing that's going to have a huge change in the next few years. And that is His bundle pacing or left bundle branch pacing. How does this work? We know that if you are able to capture the His bundle with a pacing lead, then the QRS would look exactly the same as a normal QRS. And you might wonder why a patient with left bundle branch block we should be pacing here. The science behind it is the patient has a left bundle branch block, but actually the fibers that are destroyed are more proximally in the sheath within the His bundle. So distal to that, if you are able to pace, then you get a narrow QRS. So increasingly, His bundle pacing is an alternative to CRT, even in patients with right bundle branch block or non-specific interventricular conduction defect. And this is where, see, you have right bundle branch block here, you have His bundle pacing here, and that's absolutely narrow, normal looking. But there are technical challenges to His bundle. This is one of the patients we've done. You put a His bundle catheter from below, which gives you an idea where the His bundle is. These are not deflectable or catheters with a stellate as of now. Comes with a pre-shaped sheath, which takes you to the right ventricular outflow tract. You slowly bring it back and then anchor it at the His bundle region. When it works very well, but there are issues of chronic thresholds and early battery life depletion. And therefore, right now, indicated only in patients in whom CRT is not going to work, does not work, or has not been able, we are not able to find a vein, etc. You can also similarly go from the right bundle, go through the myocardium and pace the left bundle directly. And you see here that as you go from the right bundle to the septum to the left bundle, the QRS becomes narrower and you have a right bundle morphology, and you can have resynchronization. The advantage is that you don't need a third lead, you need a regular pacing. So in countries like ours, it's much cheaper and it seems to be a doable thing. And we are again looking at, as of now, of course, guideline directed. This is only for patients who don't have, technically who have failed or regular CRT, but I think increasingly we will be doing this instead of the CRT as we know it as biventricular pacing. And now, just as I was preparing this talk, the same, Zhu, whom we all know from APHRS, has said that actually, if you're in the middle of the septum with a bipole, you can have a bilateral bundle branch pacing, which is the most physiological that you can get. So in the end, I would say that cardiac resynchronization should be considered for all patients with heart failure with reduced ejection fraction and left bundle branch block was symptomatic on guideline-directed medical therapy. Other forms of physiological pacing could increasingly play a role in failed CRT or non-conventional indication for CRT. Thank you very much.
Thank you, Professor Mahanayar, for that very informative and very interesting, comprehensive talk. And of course, for keeping it to time, you have finished well within the time. We'll take a few questions.
So we'll move on to the question answer session. I think the first question was asked by Dr. Sunit Karunaratne. I think it's directed to you, Rohan. The question is, nowadays there is a concern regarding sudden cardiac death in children and young athletes. And there are many referrals prior to sporting events. Could you please propose a simple assessment pathway for assessment of these children in Sri Lanka, in a Sri Lankan setting?
Well, Sunit, that is one of the most difficult questions to answer. And this is a difficult question for anyone in the world to answer, in fact. There is no simple assessment pathway for these patients, for these people, but they're not patients, remember. Various methods have been proposed, but they are all controversial because essentially, whatever we use, we cannot tell a child or a parent that their child who is going for competitive sports is going to be completely free of the risk of sudden cardiac death, because we don't know. Now, if you look at the methods that are used, in Europe, they're using an ECG as one of the screening methods, but this has been disputed in USA. They don't use ECGs for screening, because what they say is that if you do an ECG, that the person doing the ECG must be able to say this ECG is abnormal or normal, right? And unless they do that, what happens is the ECG is then has to be sent to somebody who can say that, and that becomes a huge cost issue. And that is what's happening in Sri Lanka. We are getting referrals saying this ECG is abnormal, but but the people who are doing that assessment are not able to say whether it's abnormal or not. And even if the ECG is normal, we know that there are arrhythmogenic syndromes which are not picked up by ECG. And even if you go through a very good clinical history, and how and can we really do that? If you have, say, in a school, we have 100 or 200 children who are going for sports, can we actually go through every one of them, go to a clinical history, ask their family history, do a clinical examination, and go through their ECGs to see whether they have anything wrong? It's not practical. So essentially, the only things we can do is we can ask for a family history of sudden cardiac death. We can assess whether they have a murmur. You can't send all these patients to echocardiograms either. Right? We can take ECG, but at that point, whoever the doctor or who is assessing these patients, these children, must be able to interpret that ECG. Because if you say for instance, if you look at the ECG and do a ECG, and you say, oh, this child is clear to do sports, and something happens, then they're going to come back to you and say, you are the one who said the ECG is normal, but here we have an abnormal ECG in this patient. So therefore, it's a very dangerous thing. So therefore, it's very important in this regard to be able to interpret that ECG. What do you think, Asango?
As Rohan pointed out, we have had several referrals with regard to this. I would rather say that if the ECG shows any abnormality, I mean, in our setting, echo is a relatively a cheap option that we can actually proceed with the echocardiogram to find out at least the referred, the relevant child has a hypertrophic cardiomyopathy, which is one of the leading causes of death. And something very similar. I don't think we can catch ARVCs unless it's full blown. And of course, WPWs can be caught, right? And then, I mean, we can proceed along the lines of possible treatment. In our setting, our options are much cheaper when it comes to the cost effectiveness. I think anybody can have ECG, and then I think it's not too difficult to reach a specialist in our setting. Any ideas, Suresh?
Yes, one of the biggest practical problems is comes with our culture also, where patients, in the sense these are young fellows, are being brought by their parents, and the parents want us to give a yes or no answer. We have a long discussion. At the end of the long discussion, what the mother asks is, doctor, can he take part in sport? After discussing everything and giving a lot of information, you want a yes or no answer, and they are not satisfied if we are, and our patients want us to tell them what to do. So that is one of the biggest problems. And even if it is a WPW, it may not be pre-excited all the time. So they are maybe intermittent pre-excitation. Even in a holter, we might not catch it. So
In fact, what I do in general situations, I go through all this and I say that as far as we can see from the ECGs and the 2D echoes, these are normal and they do not show up anything which can be a risk. However, I say we cannot say 100% that there is no risk in this child going for sports. Right? But as you say, it's the parents who push and say, "Oh, why can't he see the team? He's going to for nationals next year. Can't he go and play?" That's what they want.
Point. Mohan, do you want to add anything on to this? Is Indian scenario different?
It's a very interesting discussion, and some time back I was asked to speak on the same subject in the Asia Pacific Society of Cardiology. And you need to strike a balance. The question is whether all children who go for sports, see, because if you find these small subtle ECG changes, you don't want the child to be withheld from normal school sports. On the other hand, like all of you said, you don't want to have a sudden death, because sudden death in a football field makes big news anywhere in the world. And you can't do echo and genetic studies in all patients. So I think that where I ended that talk was to say that have a clinical history, of course. This is for competitive sports. As the patient, child does not play for the school team or the state team or the country's team unless there's been a good family history, a good ECG, and a good clinical examination. If these are all right, then the patient, child can, the person can go for, because in that case, the theoretical risk of a sudden death occurring on the field is very, very less. If you have any of these positive, then you, depending on what is positive, you go on to do genetic studies, echo, like Asanga said, echo is very simple, and especially with hypertrophic cardiomyopathy, picking up hypertrophic cardiomyopathy. WPW actually sudden death, if you've seen, most of them have SVTs before they actually have a sudden death. That is the biggest advantage. Very few of them would have their first episode during a competitive sport. But if you have these histories, and or if you have a suspicion, like we know that there are some desmosomal mutations on genetic analysis, again, depending on how much it is available in your country, you know that these with ARVC or these with the Brugada cannot be sent for any amount of competitive sport. So I think that ECG should be the baseline if it is for competitive sport. Regular sport, I think the child can do as the child needs, because you don't want the child to feel abnormal just because you found a notch on the ECG. For example, now we know that even early depolarization is a VF trigger, and you don't want these children to be unnecessarily not going for regular schools, you know. But competitive sports should have a different level. I mean, even there, the most practical is clinical examination, family history, and ECG, and then from there go ahead.
One last question from this directed towards Professor Nair. Actually, this is again from Sunet Karunaratne, who is firing questions. He is absolutely on fire today. So isn't it better to do AAI pacing for patients with sinus node disease rather than DDR pacing, which gives rise to LBB, and then consider CRT on them? A practical question in our setting.
Yes. See, honestly, you're absolutely dead on. We have a large number of 6 sinus patients who are just on single chamber AI pacing. The reason why the rest of the world puts dual chamber is because of a predicted risk of heart block in the future. But we know that we've got away with, we have younger patients, and 6 sinus syndrome, AI works very well. But even if you have a DDD pacing, we know that we have managed ventricular pacing now, which means that even in a patient with DDD, should he have an AV node dysfunction or the PR prolongation, the pacemaker looks at the best opportunity to have spontaneous right ventricular depolarization than have pacing. It's only when you have regular left ventricular, right ventricular pacing for a several years that you will have LV dysfunction. So you're absolutely right that even if you put two leads for a future heart block, you must try to, and if you look at the programming, most of these say AAI to DDR. So the default is AAI. The question is whether you want to put the second lead or not. And you're absolutely right that we have a lot of patients in whom the second lead is not put unless absolutely necessary. Some people on the table, when you have the atrial lead in, look at Wenckebach point and say that if the Wenckebach point is less than 130, then you put the RV lead also. But there's no real science behind it. So you're absolutely right that a good majority of patients with 6-sinus syndrome, relatively young, can do very well with an AI base alone. And that should be the preferred mode, for sure.
If you have in time. Now, a lot of patients that from this school screening and so on, we are getting referrals for echoes, and we see most of them having mitral regurgitation or mild form of MVP. There are reports that there is some incidents related to sudden death and this MVPs. What's your opinion on that side? Whether we can do anything for those patients? Can we recommend them going for exercise?
There are some new studies that are showing that there are a subset of patients with mitral valve prolapse who might be at a risk of sudden cardiac death. These very early stages yet. And I was speaking to Dr. Kapuat, and he was saying that there are some MRI features, I believe, which suggest that there is fibrosis of the papillary muscle apparatus, which can predict these patients with MVP who can go into develop sudden cardiac death. That's very early stages yet. And if you are going to kind of suggest that all patients with MVP are at risk of sudden cardiac death, that's going to be a huge problem. Perhaps Dr. Kapoor can say a few words about it.
Yeah, actually, there are echo features.
Sorry, Kapota, I'm going to have to disturb you.
Yeah.
I apologize. We are running short of time. We're going to have to wind up. I'm sorry. We will have the discussion during the tea time. I'm sorry about that. I'd like to thank Professor Mohan Nair for taking this, dedicating your time in spite of your very busy schedule to be with us. And hopefully when the COVID is over, or, when we are living with it, and we'll hope to see you
I'm not waiting for COVID to be over. You can call me anytime. Thank you very much.
Yeah.
Thanks.
Thank you very much, sir.
All right. Thanks for the participation.